Okay, great. Well, I'd like to thank the Hoag medical staff for giving me the opportunity to talk about my work. So the title of my talk is Fat Cancer, Liposarcoma, Current Management, Controversies, and Future Directions. So I'd like to start off with some acknowledgements. My previous institution collaborators and mentors, including Dr. Rafe Pollock, sarcoma surgeon who's now at Ohio State University, as well as members at USC, including Dr. Stephen Tseng, who recruited me, Dr. James Hu, a sarcoma medical oncologist who's also on staff here at Hoag, as well as the team here at Hoag, including Dr. Eisenberg and Dr. Nassif. And this is our team at Hoag. You can see, I don't know if you can see, but I'm actually photoshopped into that picture. But I do like to think I'm an active part of the group. You can see that the group is, our team is very multidisciplinary. It includes representation from all the different subspecialties involved in the care of sarcoma patients. So the outline of my talk, I'll start off with a few slides about soft tissue sarcoma, and then we will go into one of the specific subtypes, liposarcoma, and even within that, we'll talk about well-differentiated and dedifferentiated liposarcoma. I'll go into the clinical behavior and treatment, including some of the controversies in the field, and then I'll end with a few slides about future directions and specifically some of the research that I've been doing looking at immunotherapy as a potential treatment option in this disease. So first of all, what is sarcoma? I start off when most people think of sarcoma, they actually are referring to bone cancers, bone sarcomas. And these occur mostly in children and adolescents and young people. They include osteosarcoma, Ewing's, chondrosarcoma. There's another set of sarcomas called soft tissue sarcomas, and these are just what the name implies, that these are tumors that arise in the soft or the connective tissues. That includes fat, muscle, vessels, fibrous tissue, and these definitely are not bone sarcomas. So almost two separate diseases. Soft tissue sarcomas make up only 1% of all adult solid cancers, so they're very rare. And in terms of where they develop, in terms of anatomic location, the vast majority are actually in the arms and the legs, the upper and lower extremity. About 20% of them do occur in the retroperitoneum or intra-abdominal cavity. And these are examples of patients that I've taken care of at USC, examples of soft tissue sarcoma. You could see on this is a lipomatous tumor of the forearm. This is a radiation-associated angiosarcoma. This lady had breast conservation therapy, including whole breast irradiation, and 7-8 years later, after her breast cancer was taken care of, she developed angiosarcoma as a result of the radiation. And then up on the top corner there is a patient that had neurofibromatosis and developed a sarcoma that turned out to be a malignant peripheral nerve sheath tumor. So one unifying theme of all soft tissue sarcomas is that grade is very important. As one of my mentors told me, grade is the window into disease biology. And there's two main grading systems that we use in sarcoma. The one that's most commonly used, though, is the French grading system. You can see with this survival plot here that the grade really makes an impact. The higher the grade, the lower the survival. Now, the WHO, World Health Organization, does have a classification scheme for soft tissue sarcomas, and the point of this is to illustrate that beyond grade, the soft tissue sarcomas are very diverse. They're very, very heterogeneous, and there's over 50 now, we think probably 70 different subtypes of soft tissue sarcoma. And as I like to tell residents and medical students up at USC, it's the differences between each of the subtypes is sometimes profound enough. It's almost like saying breast cancer compared to prostate cancer compared to colon cancer. We know that a lot of the soft tissue sarcomas have distinct genetic abnormalities. This again illustrates how diverse and heterogeneous the different subtypes are. The majority of these genetic abnormalities are actually translocations. So they're portions of a chromosome that move to another portion of the chromosome. They have distinct clinical behavior. So on the left here is a list of different subtypes of soft tissue sarcoma. And then on the right here are different clinical behaviors. And you can see that each one has a unique clinical behavior that's unique to that subtype. For example, the desmoid tumors, they never metastasize. If you have an NF1 patient, you think of MPNST. And the majority of soft tissue sarcomas do not go to the lymph nodes. However, there are specific subtypes in which you can expect lymph node metastasis. So sometimes I like to say it's like wine in terms of the heterogeneity of soft tissue sarcoma. To the physician that doesn't really, or the healthcare provider that doesn't really see sarcomas on a regular basis, it may be just the difference between red wine, white wine, dessert wines, but in reality there's a lot of subtleties, a lot of nuances in between or among the different subtypes of soft tissue sarcoma. I'm not really a wine person, so another analogy would be ice cream. It's like different flavors of ice cream. But the point is, defining the histologic subtype is very critical for soft tissue sarcoma. So on to liposarcoma. So among the different subtypes, so liposarcoma makes up, it's actually, there's 3 subtypes of liposarcoma, but it's only a group of the overall diversity of soft tissue sarcomas. Within liposarcoma, there are 3 subtypes. There's the well-differentiated, dedifferentiated type, myxoid or round cell, and pleomorphic. You can see that there's distinct genetic or molecular aberrations associated with each of the different subtypes of liposarcoma. And by histology, they also look different from one another. A and B represent, this is a well-differentiated liposarcoma. This is a dedifferentiated liposarcoma. That's what myxoid looks like, and that's what pleomorphic looks like. I will say that oftentimes it's not as clear-cut, and there can be overlaps in terms of how they look under the microscope. And that's where the molecular testing comes in. If you can show that the tissue you're looking at has a particular translocation, that would put it in the category of, say, myxoid liposarcoma. In addition to that, so each of the 3 different subtypes have distinct clinical behaviors and different responses to therapy, to chemotherapy, to radiation therapy. So well-differentiated, dedifferentiated liposarcoma, so that is my personal interest, clinical interest, research interest. And the reason why I'm so interested in this is because among the 3 different subtypes of liposarcoma, it is the most common. And overall, for all the 50 to 70 different subtypes, it's also one of the most common of all soft tissue sarcomas. It's also the closest to fat cancer among the 3 different subtypes. And there's no clear relation to obesity. So I think just the fact that it's a fat cancer is interesting to me. But there's two varieties, well-differentiated and dedifferentiated. And the reason why they are called that way is because the well-differentiated is low grade and the dedifferentiated is high grade. So the histology looks very different for the well-differentiated tumor versus the dedifferentiated tumor. You can see the well-differentiated looks like it's mostly fat, adipocytes, but if you look closely, the adipocytes are often big adipocytes, small adipocytes. It's a kind of a disarray with a lot of fibrous stroma. And then the dedifferentiated portion tends to not have the adipocytes anymore, and it tends to be very cellular. All of these black dots are all the nuclei for the tumor cells. So when a pathologist looks at a tumor under the specimen, what they often see is a juxtaposition of well-differentiated and dedifferentiated components. And it's often a very clear demarcation between the well-differentiated part of the tumor and the dedifferentiated part of the tumor. Grossly, the tumors that I remove, this also applies, the clear demarcation, because you can see the well-differentiated portion of the tumor that essentially looks like an encapsulated ball of fat, whereas the dedifferentiated portion doesn't look so much like fat and tends to be more vascular. Going back to the genetics just briefly, so what's interesting is that even though they look differently under the microscope and grossly when you take out the tumor, the genetics are fairly similar, at least on the superficial level. If you do karyotypes on these tumors, the tumor cells, you'll see these abnormal ring chromosomes. And then the hallmark feature of well-differentiated, dedifferentiated liposarcoma is amplification of a specific segment of chromosome 12. We don't know why, but in fact, the molecular testing that we do to try to prove that a tissue sample, a tumor, is this histology often relies on the presence of this amplification or genes within that area that are amplified. And this does include thousands of genes. Some of the more important ones, MDM2, CDK4, those are involved in cell cycle regulation. I will point out, though, that unlike other cancers, there are or very few mutations that have been ever described or reported for this disease. But it does get a little bit more complicated than that, and this is unpublished data from Ohio State and the Mayo Clinic. And when they look at the gene expression profile, so each of those individual boxes, red or green, is a individual gene. And red means that the gene is downregulated, so you can think of it as turned off, whereas green is upregulated, so it's turned on. And you could see on the left here, these are the well-differentiated samples, these are the right, and it's clearly there's a difference in terms of the expression levels of various genes for well-differentiated versus dedifferentiated liposarcoma. Again, very few or no mutations. So it gets even more interesting because the dedifferentiated portion, the high-grade portion, can, in some cases, you can see evidence of other tissues. So even though it's a fat cancer, you can actually see evidence of skeletal muscle. You can see evidence of bone, smooth muscle, and in this particular report from MD Anderson, and there's several others since then that have reported this, the non-fatty differentiation can get to the point where it looks like another sarcoma. So as in this case, the patients that were described had liposarcoma, and essentially within that they had a rhabdomyosarcoma, which is a skeletal muscle sarcoma. So, and blood vessel angiosarcoma is possible. So from a research standpoint, it's very interesting because it implies that within that dedifferentiated portion, there probably are cancer stem cells. They have the ability to form fat, but they can form all these other tissue elements. So back to clinical behavior and treatment. So well-differentiated, dedifferentiated liposarcoma, again, they look very differently by histology, and clinical behavior mirrors that as well. Well-differentiated liposarcoma tends to be very indolent and does not metastasize, whereas dedifferentiated liposarcoma is more aggressive, and it does have a modest frequency, 10 to 20%. Some other series suggest maybe 20, 30% rate of distant metastasis, and that most commonly occurs in the lungs. But both, whether you have well-differentiated or dedifferentiated liposarcoma, cause significant local morbidity. So again, dedifferentiated liposarcoma is associated with worse clinical outcome. That's both in terms of recurrence-free survival as well as overall survival compared to well-differentiated liposarcoma. So the treatment for this disease is surgery, and this is what I do. I'm a surgeon, cancer surgeon. And oftentimes that's what it looks like when you take the tumor out. So I'll show you some other clinical examples, some other patient examples. This is a patient at LA County Hospital that I treated. You could see that's his left leg. He has a pretty large tumor that's causing venous obstruction. He has varicosities. That's his MRI. You see a large lipomatous fatty, essentially same consistency, same density as the subcutaneous fat, but well encapsulated right next to the knee. At the time of surgery, that's what the tumor looked like, and it was, in fact, involving the saphenous vein and compressing the saphenous vein. That's what it looked like after resection. I had to take a portion of the muscle. This is another case. This is a retroperitoneal liposarcoma. And you can see that it's a huge tumor, needless to say. What's interesting, though, is oftentimes looking at just the radiology, just looking at the cross-sectional imaging, you can kind of tell that the tumor is well-differentiated and well-differentiated. You can distinguish, I should say, between the well-differentiated and the dedifferentiated portion, or at least you can get a hint of it. The dedifferentiated portion, the only way to definitively diagnose that is by pathology, by histologic criteria. But you can kind of get an idea, because the well-differentiated portion, again, it looks just like kind of a dirty fat, whereas the dedifferentiated portion has what the radiologists often call a soft tissue or water density. Given that as you would expect with such a huge tumor, it compresses or comes close to important structures such as the IVC and the aorta. That's what it looked like at the time of surgery. This is the head of the patient is here, the feet are down here. In fact, these are his femoral pulses right here that I marked out. That's essentially a stem to stern incision, and you could see the tumor takes up the entire opening of the patient. There's the left colon stretched out, and then once we got the specimen out, the colon de-stretches. And this one was 50 centimeters and weighed 20 pounds. So this actually turned out, despite what I just said about the radiology, this one actually turned out to be not dedifferentiated, but just a more cellular, well-differentiated liposarcoma. And then one more case. So this was another patient at USC that I took care of recently who had a resection back in 2007 and then presented to me in around February, about April or so, with the CT scan that looked like this. And essentially you could see a big tumor there. And the dedifferentiated, if you study these carefully enough, you'll be able to see the dedifferentiated, but more importantly, the well-differentiated portion is a dirty-looking fat that essentially encompasses the right kidney. So if you study the CT scan long enough, and I usually do before taking these patients to surgery, you could see that we talked about the kidney. The inferior vena cava is actually compressed, and it looked inseparable from the tumor. And in addition, the right colon is squished in between parts of the tumor, as well as the duodenum. There's a little contrast there in that's probably the second portion of the duodenum. And then the pancreas and the superior mesenteric vein are right in that area. So knowing that, we took the patient to surgery, and this surgery entailed removing the right colon, removing the right kidney, doing a Whipple procedure, so taking out the pancreas, duodenum, head of the pancreas, duodenum, also a partial hepatectomy. We had to take part of segment 5 because of tumor involvement. And probably the more tedious part was dissecting the tumor off the inferior vena cava, superior mesenteric artery, and vein, which, remind you guys, that's the blood supply to the intestines. So it was a very challenging operation. That's what the tumor looked like. This is a 20-hour operation, by the way, multiple teams. And the final diagnosis was this was a dedifferentiated liposarcoma. So there's controversy in the field, at least the surgery side of things, in terms of how big of an operation to do in these patients. And most of this controversy, we call this, it's a transatlantic debate between the European groups, which are in Milan, Alessandro Gronchi and Sylvie Bonvalot in Paris, and the U.S. groups, mostly MD Anderson and Memorial Sloan Kettering. There's this idea of compartmental resection, and what that means is if you have a patient with a retroperitoneal sarcoma, and so not just liposarcoma, but just any sarcoma, soft tissue sarcoma in the retroperitoneum, if you have a tumor such as the one there circled in green, what the European surgeons advocate is not just removing the tumor, but removing all of the organs and structures around it, even if it's not involved. And that's the critical part of it, even if it's not involved. So even if it's touching up against it, they will remove the kidney. They'll essentially, for liposarcomas, they'll clear all of the fat in that area. So this patient lost the kidney and essentially had a skeletonized aorta. You can see the IVC there. I'm sure lost colon. And so it's an even bigger operation than what you would think of doing. And they've published several papers in prominent journals, high-impact journals, about how this surgical technique of compartmental resection does lead to better local control. It has lower rate of local regional recurrence compared to just resecting the tumor itself. The idea behind this is it's a question of margins. We often talk about margins in other cancers, and in sarcoma, it's hard to really define margins because you could see that we have giant tumors that if you really wanted to get adequate margins, that would mean basically taking everything out, or at least taking a part of everything out in the entire abdomen. But this concept of compartmental resection, so it's very controversial. The U.S. side of the debate argues that it's associated with high morbidity rates, and it's also, there's no improvement in overall survival. Now, that little asterisk is to remind me that there was a recent report from Gronke's group in Milan that did show an improvement in overall survival after 5 years. But it still is associated with high morbidity rates. And in fact, if you look at the original reports, the French group had up to 20% take-back rate, taking the patients back to the operating room because of complications related to this procedure. So you could imagine this sparked a lot of debate. There were a lot of editorials that were published, both pros and cons. When I was at MD Anderson, I had a chance to look at the series of liposarcoma patients that were treated at MD Anderson, which is about 250-some patients. And we actually found the phenomenon. So this is arguing against doing compartmental resection. And the argument is that sometimes in a certain percentage of patients, about 10-20% of patients, if you have a big tumor, what will happen after you resect that tumor is that you'll develop a recurrence in an area outside field. So as in this example, there's a tumor here in green. These are interval scans and interval post-op scans. And then a couple years later, so the patient developed recurrence in that same area, but on the opposite side where there was originally no tumor, the patient developed a recurrence. So that's why we at MD Anderson, we advocated not doing compartmental resection because of the high morbidity and the chance that patients would fail regardless. So again, the primary treatment is surgery, but it's, as you can see, it's very challenging and recurrence occurs very frequently. So you may be asking, what about non-surgical treatments? So radiation therapy, we don't really know if this is effective or not. And if you were to give radiation therapy for the retroperitoneum of the abdomen, it would be in the neoadjuvant setting, so before surgery. And the reason for that is because the bowels are pushed away and you minimize any toxicity you give to bowel from radiation. There is a large European study, EORTC STRASS trial, STRASS, that's trying to evaluate the role of radiation therapy in soft tissue sarcoma. But for now, we don't have good evidence to say one way or another, does it help or does it not help. Chemotherapy, standard chemotherapy, which is in liposarcoma is doxorubicin based, is really not all that effective. So when you look at objective response rate, which is the rate of partial response plus complete response, or essentially it's tumor shrinkage, the response rate is only 12%. So only 12% of your tumors get any sort of shrinkage with chemotherapy. Targeted therapy, so again, getting back to, remember the genetics of this disease with the 12q amplification has important genes, and if you inhibit those genes, the studies we have so far that are mostly phase 1 and early phase 2 suggest that the response rate is even worse than chemotherapy. Yes?
So I have a question. There's some things going on in cosmetic dermatology that are targeting fat.
Mm-hmm.
And so that actually might be something we're doing a study for, something like the surfactant, like Kybella, that they're doing for submental fat deposits, and maybe see if some liposarcoma.
Yeah. That's actually I think that's a great idea, something we could certainly test, at least in vitro. Oh, I'm sorry. She was saying that there are certain things they use in dermatology that basically target fat and try to get rid of fat, is it? And maybe those can be tested out in liposarcoma. Adipocyte necrosis, yeah.
Selective adipocyte necrosis.
Yeah, yeah. Yeah, no, I think that's a great idea. And actually, I don't have a slide about this, but at City of Hope, there's actually an investigator over there that looked at HIV patients who get lipodystrophy and fat distribution in different parts of their body, and there are particular drugs that are associated with lipodystrophy. And so he essentially took that drug, tested it out in vitro in a petri dish to see if it caused adipocyte necrosis, and it did, and then that led to a clinical trial, but it didn't work in the clinical trial side of things. So, but it's an interesting idea. Yeah, yeah.
What I'm talking about is targeted adipocyte necrosis.
Yeah.
If it's something deep, it could be like the injectable that just got FDA approved in June.
Uh-huh.
Or, it's more superficial. There's things like cool sculpting that cause selective adipocyte necrosis if it's superficial, but obviously for deep it doesn't. You would probably want to try the injection.
Inject it, yeah. That's an interesting idea. I think certainly worth pursuing. Yeah. Okay, so that's the treatment for liposarcoma, and essentially it is relentless. The disease is, the only thing progressing is the disease. So you still may be asking, why study this disease? It's so rare. It's probably not, it's very rare. So I think the reasons for studying this disease are that, well, number one, there's no good treatment for these patients. And then from a disease biology standpoint, from a research standpoint, it's interesting to me that the same tumor can have components of a low-grade, high-grade component, and then in some tumors that metastasize, there is a part of that tumor that's also high-grade with potential for metastasis. That all can occur within the same tumor. And I can't really think of any other cancer where you see that so frequently, all in the same tumor. I've shown you some evidence with lineage differentiation that the high-grade portion can do this, and so it implies that there are possibly cancer stem cells in this tumor. And then there's also the question of lipomas. Now, liposarcomas are rare, but lipomas, benign lipomas, are common. So the question is then, what's the relationship between this liposarcoma, which is the closest to, it is a fat cancer, but it's the closest to a benign lipoma among all the different subtypes. Then there's also the question of obesity, and I put that as a thing on the side because we really don't see a clear association with obesity, but this is a problem of fat. It may be an encapsulated problem of fat. We don't really know. And then for research purposes, there's always ample tissue, so that's good. The question about lipoma versus well-differentiated liposarcoma. So this is one of several reports out there that have looked at the genetics of both diseases, and the conclusion is that there may be some sort of a relationship between the two. This is very controversial. I can tell you the pathologists, everybody at MD Anderson thinks that this is just, it's not good data. But there are other places, other reports from around the world that suggest there may be a connection. So finally, I'll talk a little bit about future directions and specifically immunotherapy, which is my research interest. So improving survival in cancer, that's ultimately what we want to do for these patients, whether it's liposarcoma or any other cancer. And most therapies that we have nowadays, including cytotoxic chemotherapy as well as targeted therapy, they do prolong survival to a certain extent, but all the patients ultimately die. After a period of time, that curve just reaches to the bottom. So with immunotherapy, what we've seen in other solid cancers such as melanoma, and as we're starting to see in lung cancer and bladder cancer, if you have a patient with cancer that you treat with immunotherapy, if they respond, now it's not all patients that respond, but if they respond, they have the potential for that survival curve to have a plateau. And what that plateau means is that you have a long-term survivor. The goal that we try to get with immunotherapy is an objective response. It's what I mentioned earlier in the previous slide, which is tumor shrinkage. And specifically, radiologic criteria, it says that it's about a 30% shrinkage in the tumor. Because if you get a shrinkage in the tumor, it makes sense. If you get a shrinkage in the tumor, then you're more likely to get improved survival. For me, as a surgeon, if I get tumor shrinkage, it's great because then it can, if I give it to the patient before surgery, it may help facilitate a resection or make resection easier for me. So just to go back for a couple, just for a little bit about basic immunology, going back to kind of medical school for most of us. So the key players are the dendritic cell, which is involved in presenting antigen. And then you also have your CD4 helper T cell, as well as your cytotoxic CD8 T cell. Cytotoxic meaning in this case, it attacks the tumor cell. It's that CD8 T cell that's the one most responsible for killing tumor cells. The reality is within the tumor, there's a lot of other players, NK cells, macrophages, B cells, and it's really a balance of good cells and bad cells that determines ultimately what the outcome of the tumor is in terms of whether it shrinks or whether it grows. This is just referring to the natural immune response, not referring to treatment. So this is what happens, this is what we believe happens in the tumor microenvironment in terms of the immune response. So the tumor cells, which are shown here in brown, over a period of time, what happens is some tumor cells will die spontaneously, and then they'll release antigen, which is this yellow squiggle. Antigen is usually a peptide. It's a chain of amino acids. And then in the tumor microenvironment, you have this cell called the dendritic cell, which is involved in picking up that antigen, internalizing it, and then they usually go to the lymph nodes, where with that one specific antigen that it's internalized, it encounters a naive T cell, and then it educates that T cell to that specific antigen. And that's kind of the beauty of the immune response, is that it is a very specific process. So those T cells, now that it's been educated to that particular antigen, it goes back out into the periphery, away from the lymph node, back into hopefully the tumor microenvironment. And then when it encounters a tumor cell with that same antigen, then it knows to attack. The reality, as I said, are good cells and bad cells. So the tumor often has cells, actually immune cells, that are designed to help prevent this attack from happening. So in liposarcoma, when I was at MD Anderson, we observed in the lab that what's interesting is within the tumor, you get these clusters of immune cells, these aggregates of immune cells. Doing some immunohistochemistry, we found that these are definitely high in T cells, specifically CD4 helper T cells. They're also very high in B cells, CD20 B cells. The CD8 T cells that I said are more the ones responsible for tumor cell killing. They're typically scattered throughout the rest of the tumor and not found in these lymphocyte clusters. And NK cells are just rare overall in the tumor. So again, these are what they look like, and in the literature for other cancers, these are described, other cancers in actually chronic inflammatory states. These are described as tertiary lymphoid structures. And that's what it looks like under higher magnification. And if you think of these immune cells as your soldiers, like your army that's going out to attack the bad guys, the enemy, the tumor cell. So I like to think of these lymphoid clusters, these lymphocyte clusters, as basically the command center. And I'll show you some evidence to support that. It's not just my imagination. But these are kind of the command centers, and then out in the periphery, out into the tumor, this is the tumor nodule here, that's where your foot soldiers, your CD8 T cells are found. This is another example, a case at USC, or a patient in the tumor at USC. And the same thing, you have a command center and foot soldiers in the periphery. These do tend to occur next to blood vessels. These are vascular channels. And I have to give credit, this analogy was actually brought up by James Hu, our medical oncologist, that he has a background in the military. And this is an example at Hoag, a patient that I took care of at Hoag. This patient, it was actually a very interesting case, and I'm still following this patient in clinic. He had sigmoid colon cancer. That was his primary diagnosis. He was taken to surgery for resection of his sigmoid colon cancer. And at the time of surgery, the surgeon found a suspicious-looking nodule in the mesentery of the small bowel, so separate from the sigmoid colon cancer, in fact, far away. In fact, what he ended up doing was biopsying it, taking pieces of it for frozen section, eventually for permanent, and he left some clips there. That's what's in that green circle. So that came back to be liposarcoma. And in fact, it came back to be dedifferentiated, the more high-grade liposarcoma. And I bring this case up because this case also demonstrates presence of the command centers, these tertiary lymphoid structures. Part of the reason why I call these command centers is because some of the work that I did at MD Anderson showed that within them you can actually find dendritic cells. Again, those are the cells that present antigen, that educate the immune system to the antigen, the tumor antigen. So essentially, going back to our original diagram, those tertiary lymphoid structures represent this part of that immune response. What's also interesting, though, is that as opposed to other cancers where this immune response takes place in the lymph nodes, this is actually occurring within the tumor. So it's actually an active immune response that's occurring within the parenchyma of the tumor. So, and I should say we're still trying to, that's the focus of my research, is trying to really define what the purpose of the immune makeup, to really just figure out what the importance of this. Because if you kind of stand back and think about it, the tumor is continuing to grow despite the presence of these tertiary lymphoid structures. Then there's the other arm of the immune system, which are essentially the foot soldiers, and these are the CD8 T cells. So this is flow cytometry, and we looked at within the tumors, within liposarcoma tumors, and there definitely are CD8 T cells. They make up about 20% of the population of all of the T cells found within the tumor. By immunohistochemistry, they're definitely there, again, within the tumor. These are the foot soldiers. And over several samples, it's pretty much about 20% of the T cells are CD8. So the T cells are there. The question is, the foot soldiers are there in the tumor microenvironment, and you also have a command center that's trying to lead this army attack against the liposarcoma. So the question, why isn't it working? We do know that in the immunology field and immunotherapy field now, that when T cells are activated, they have signals that tell them to keep on going, that keep them turned on. But at the same time, they have these signals that tell them to turn off. And these signals come on independent of the tumor or whatever's in the environment. It's kind of like a wind-up toy. When you wind it up, eventually it'll turn off by itself. And then sometimes the tumor has signals that basically initiate these stop signals. So we looked at these signals in liposarcoma, and we found that the CD8 T cells, the foot soldiers, do actually have these stop signals. And in fact, the majority, about 2/3 of the foot soldiers that you find in the tumor microenvironment have this PD-1 signal. So this finding actually led to, we put together a clinical trial to look at use of drugs that are being used now in melanoma and also in lung cancer. These are anti-PD-1 drugs. So we've put together a clinical trial design and submitted to Bristol Myers Squibb. And the last that I heard, they're still considering it. They haven't rejected it yet, so I don't know, hopefully at some point. But along that same line, those same drugs, the anti-PD-1, so the name for it is pembrolizumab. So there is a trial that is currently open. In fact, it's close to closing, that looks at using that mechanism of immunotherapy, that strategy of immunotherapy in advanced sarcomas. So this includes liposarcoma, but includes all the other subtypes of sarcoma. And there's the clinical trial design. It's essentially soft tissue as well as bone sarcomas. And the endpoint is looking at objective response, at tumor shrinkage. There isn't any data to report for this yet. It's the study's still open, just nearly closing. But University of Southern California, USC, we are one of the sites, one of the 10 or so sites selected for this trial. And in fact, Hoag is part of this trial as well. In fact, we enrolled, I know, at least of one patient from Hoag that was part of this. So that pretty much is it for my talk. Just to summarize, soft tissue sarcomas encompass about 50 to up to 70 different histologic subtypes, including liposarcoma, which is only one of the many subtypes. Well-differentiated, dedifferentiated liposarcoma, I think, is a fascinating disease just because of the fact that it's a spectrum from low grade to high grade, often within the same tumor. And then the treatment for liposarcoma currently is surgery, centers around surgery, but it can be very challenging and recurrence occurs very frequently. And we don't have effective, we don't have proven radiation benefit with radiation therapy, and systemic therapy really doesn't work that well. So further research is needed to help guide potential strategies such as immunotherapy, which is what I'm working on. So hopefully in a few years we'll have something. So again, sarcoma can be relentless. It's the only thing progressing is the disease. And my response to that was coming back from Houston to Los Angeles at LA International Airport, or actually this was, well anyways, at LAX, is to be relentless. So I want to thank everybody for their attention, and as we say at USC, fight on. I'd be happy to answer any questions.
What happened to the patient that you did the 20-hour surgery?
Yeah, he did okay. He stayed in the hospital about 2 weeks because he had a pneumonia post-op. And then he was transferred to a skilled nursing facility, and he actually just went home 2 days ago. So he actually did okay. It was we were very watchful over him. Yeah.
This business of immunotherapy is very exciting.
Yeah.
I have a friend that I referred to USC, and they had metastatic renal tumor. Lung, and it is now shrunk from 7 centimeters to 4.5.
Yeah.
Just
three cycles. Yeah.
I don't know if he's getting the same drug.
Yeah, he could be. So it's interesting because renal cell and melanoma actually they're two of the most sensitive or susceptible to immunotherapy. And we think that's because they naturally have an immune response going on. And so as clinicians, all that we're doing is trying to enhance that immune response, as opposed to something like pancreatic cancer, where there are immune cells, but it's not as vigorous of a natural immune response. And that's why a lot of these immune therapy drugs aren't working so well, at least initially in something like pancreatic cancer. But what's interesting about the response that we see with immunotherapy is that sometimes the tumors actually grow bigger before they grow smaller. And the thought behind that is that may be immune cells that are infiltrating, additional immune cells that are infiltrating into the tumor. And so by CT scan, by x-rays, it looks bigger, and then it starts to shrink. So, yeah.
Are you seeing any bad reactions such as iritis or anything?
You can with these drugs. So with the immunotherapies, that's a very good point. They actually introduce entirely new toxicities or side effects that we don't see with chemotherapy, and the majority of them, in fact, all of them are autoimmune. So for the original drug, ipilimumab, the main toxicity is colitis. So the immune cells would attack not just the tumor cells, but they'll attack the lining of the mucosa in the colon, and then the patients will have colitis. It can get to the point where they have perforation. Usually starts off as diarrhea, and then if that doesn't get treated and the patient gets worse, that could be a colon perforation. Yeah.
Are they doing any research with taking out the tumor and perhaps finding a differentiated tumor and exposing the patient's dendritic cells to that and then using reactivated dendritic cells?
Yeah, that's a good question. Not as far as I know. There's for this disease, liposarcoma, there's not a whole lot in terms of immunotherapy. As the last time I checked, the work that I've published is actually the only work in immunology and immunotherapy in this disease. I don't know if that means I'll get grants or not, but okay. I will. Okay, thank you again.